Hi, this is your medical director doing Cot-Side Chats by Dr. R. Today we're going to look at bag valve mask, and with this it's a very basic technique that we all need to know how to use and is done improperly very commonly. And we're just going to go through all the basics of it today. Number one, we want to start with our face mask. And with the face mask, we want the face mask to fit properly. Now, number one, it can only be inflated partially. If you have this inflated to its maximum amount, it won't be able to fit into the nooks and crannies of the face when we put it on there and get a better seal. The second part now is the actual placement on the face. We want to take the inside diameter of the mask, and it comes over the bridge of the nose. The inside diameter of the lower part of the mask comes to just above the chin. So we're sitting like this when we have proper positioning of our mask. Now, if we have a patient who is breathing, then we are going to assist their breathing. So that means as they inhale, we'll put positive pressure in there. We're basically assisting them with a CPAP type of device at that point, pushing some air down in there, trying to keep it out of their stomach, trying to get it into their lungs. If the patient is not breathing spontaneously, then we just initiate bag valve mask. Now, technique, we need to have our mask hooked up to oxygen. We'll have our bag fully inflated. We'll bring our mask in, goes over the bridge of the nose, down over the lower mouth, and then we do a C-E. A C-E. So we put a C on here. Oops. We put a C on here, and then the E comes along the mandible. So here's our C, there's our E. And now we have a good hold on our mask and good application to the patient's face. Now, positioning is very important as well. We want to try to open up the airway as much as possible. And as we've heard over and over again, we look at the sniffing technique to open up the airway. To give you an example of that, we want to be something like this. This way, the tragus of your ear is kind of lined up with your larynx, and that's opening this whole airway up to allow air down through there better. It's also the technique that we use when we go to intubation. So now then, we're doing our bag valve mask, and we're not ventilating the patient. So we're trying, we're bagging, we're not getting any air through there. So the most common thing to be obstructing that is going to be the tongue. Some of the simple things we can do, we just want to do a little jaw thrust. We can pull that up as we're doing the bagging. We can reposition the head a little bit. If that doesn't help, then the next technique is we need to try to remove that tongue off the back of the throat mechanically. The patient, if they are awake at all, then we're going to use the nasal airway. And with the nasal airway, we need to lube it up real good. We're going to want it to go from the nose to about the corner of the angle of the mandible there, and that should be a good length. That will help get the tongue off the back of the throat. Now we'll lube it up real good. So we lube it up, and the tapered part goes along the septum. So you look and see, is one side, does it have more room than the other? We go straight down through there, passing it in. And now then, this is in the awake patient. Now we can try bagging them again. So we place this on, bag, still no luck. Now if the patient's unconscious, we can go to the oral airway. Again, we go from about the center of the mouth to about the angle of the mandible there. And again, this is to be used to remove or to move the tongue off the back of the throat. In the pediatric patient, we want to look with a tongue blade and actually put this in straight. That way it keeps us from pushing the tongue to the back of the throat. In the older patients, say over about 8 or so, typically we're going to put it in upside down and then flip it into place. Now then we have both a nasal airway and an oral airway trying to open up the airway as best as we can for a bag valve mask. Once again, we come back, place our mask in. We've got our C-E-E, we're bagging. Still no air movement. If we have no air movement at that point, we can add a second nasal trumpet, or we can move on to two-man bag valve mask. With two-man bag valve mask, we now have one person who's doing a double C, a double E, and their only job is to maintain the face mask and try to improve the ability to ventilate. So now that I'm holding the mask, I've got a double C and a double E, and my associate then is bagging. If we're still unable to ventilate at this point, we have to find another way. But the vast majority of patients, if we do two-man bag valve mask, nasal airway, oral airway, double C, double E, we're going to be able to ventilate just about everybody. This is a very good technique. It's a lifesaver. I always say patients don't die from lack of intubation, they die from lack of ventilation. And with good technique, we can ventilate almost everybody with this. This is Dr. Richardson. I'll see you next time.